Hello, friends. Welcome back to my YouTube channel Pathology Academy. I'm Dr. Aditi Kumar, and today I will be talking about malignant melanoma. So, let's get started. Malignant melanoma is a highly aggressive neoplasm of melanocytes, the pigment producing cells in the basal layer of epidermis. It accounts for about 4% of skin cancers but causes more than 75% of skin cancer deaths. Most common in fair skinned individuals, and risk increases with UV exposure, sunburns, and family history. Talking about the risk factors, UVB exposure, dysplastic nevi, and positive family history are risk factors for development of malignant melanoma. Fair skin individuals and light eyes individuals or red or blonde hair individuals which have less melanin production have a higher risk of developing malignant melanoma. Patients with immunosuppression, like recipients of the transplant and HIV patients, have a higher risk of developing malignant melanoma. Also, xeroderma pigmentosum patients have a higher risk of development of malignant melanoma. Most common driver mutations in say 40 to 60% cases are the BRAF V600E mutation. Other mutations which are implicated in the pathogenesis are NRAS mutations, CDKN2A mutations, and PTEN loss. Talking about the ABCDEs of the malignant melanoma for clinical diagnosis, where clinically these lesions are asymmetrical with irregular ragged or blurred border with variegated colors, black, brown, etc. Diameter is more than 6 millimeter and it changes in size, shape, or symptoms. There are five histological subtypes: superficial spreading, nodular melanoma, lentigo maligna melanoma, acral lentiginous, and desmoplastic melanoma. The superficial spreading is most common type. In this, radial growth phase is seen and it involves the trunks and the limbs. The nodular melanoma has a rapid vertical growth with poor prognosis. Lentigo maligna melanoma is seen in elderly people with sun damaged skin and it has a slow radial growth. Acral lentiginous melanoma commonly affects the palms, soles, and undernails of people. Desmoplastic melanoma, mainly in this, the tumor cells are spindle cells, often amelanotic with a neurotropic behavior. Talking about the histology of malignant melanoma, well, you can see in this atypical melanocytes invading the dermis, nuclear pleomorphism, mitosis, melanin pigment might be absent. In some conditions, pagetoid spread, that is upward migration of melanocytes. Immunohistochemistry, you will find positivity for S100, HMB45, and melan A, also of SOX10. However, it will be negative for cytokeratin. Here you can appreciate the gross and macroscopic image of the malignant melanoma. As I have told you while I was telling you about the ABCD in the clinical features of malignant melanoma, its asymmetrical, irregular borders are quite evident here with darkish brown pigmentation. It can change shape and size. And in a histological picture, you can see there are melanoma cells within the dermis and fine melanin pigment within those melanocytes. Mitotic figures are also quite evident. Talking about the prognostic factors, breast lobe thickness is most important prognostic indicator. Ulceration worsens the prognosis. Mitotic rate if high, then the tumor is aggressive. Presence of lymphovascular invasion indicates the metastatic potential, and sentinel lymph node positivity predicts recurrence or metastasis. According to TNM based AGCC staging, stage 1 to 2 are localized, stage 3 regional lymph node involvement is seen, and in stage 4 distant metastasis is seen. Now let's discuss the treatment options. If the disease is localized, then wide local excision with margins is done. Node positive sentinel lymph node biopsy plus minus complete dissection is done. In advanced or metastatic cases, immunotherapy or targeted therapy is done, and radiotherapy is given for palliation or brain metastasis. Breast thickness refers to the measured depth in millimeters of invasion of a melanoma from the top of the granular layer of the epidermis to the deepest point of tumor penetration in the dermis or subcutis. If the thickness is equal to or less than zero point 0.8 millimeter without ulceration, it is AJCCT category T1A and the prognosis is excellent. However, if it is less than or equal to zero point 0.8 millimeter with ulceration, the stage is T1B and has a higher risk than T1A. In zero point 0.8 to 1 millimeter is the thickness, then T1B stage and sentinel lymph node biopsy may be considered. If the breast thickness is 1.01 to 2 millimeter, then it is considered as T2 stage and has an intermediate risk of metastasis or recurrence. If the breast thickness is 2.01 to 4 millimeter, then the AJCCT category is T3 and there is high risk of recurrence or metastasis. And if the thickness is more than 4 millimeter, there is very high risk of recurrence and metastasis. The breast lobe thickness directly correlates with 10-year survival or the prognosis. If it gives a guide to wide local excision margins, sentinel node biopsy is considered when the thickness is more than zero point 0.8 millimeter or ulceration is present. And adjuvant therapy, if the higher thickness may require immunotherapy or targeted therapy. Surgical margins based on breast lobe depth. If the breast lobe thickness is, if there is melanoma in situ, the recommended margin is zero point 0.5 to 1 centimeter. If it is less than 1 or equal to 1 millimeter, then the recommended margin is 1 centimeter. If the breast lobe thickness is 1 to 2 millimeter, then the recommended margin is 1 to 2 centimeter. And if it is more than 2 millimeter, then 2 centimeter. There is another way of dividing the malignant melanoma from level 1 to level 5 according to the Clark levels. In Clark level 1, if the melanoma spreads till the epidermis, then it is level 1. If it spreads to the papillary dermis, it's level 2. If it spreads to the papillary reticular dermal interface, it's level 3. If it extends into the reticular dermis, it's level 4. And if it goes to subcutaneous tissue, it's level 5.